I do have a button that says Trauma Queen. I actually have it on my ID. I actually am really happy to be here today and delighted to be able to give a similar talk to the one that I gave at the last SAGES meeting, but there's been a lot of updates. As you know, we've had a lot going on in the last 2.5 years. And this is one area where there's been a tremendous amount of development actually during the pandemic because there's been such a focus on telemedicine. And these are my disclosures. I'm both a minimally and maximally invasive surgeon, so that's why I'm here. So telehealth adoption during the COVID-19 pandemic, this slide I showed last year, it's hard to get this data out because it has to be accrued over time, and we're now just starting to internalize what happened to us over the last 2.5 years. But I think some of the early data that came out when we were showing what happened right after the CARES Act was enacted was that facilitators of telemedicine in institutions were, there's a fear of infection, this sense that we needed to keep the doors open and care for people despite the fact that we were going through an infection crisis. And there were some regulatory changes that made that possible. So the implementation science that really pushed this forward was that we had a financial incentive to be able to do this. So I applaud Dr. Tellem and all of her efforts in implementation science. The rest of this talk may be about the failure of implementation in telemedicine. Although it was convenient for a lot of people, there was a lot of resistance in the adoption. And in fact, I have 2 studies, both of them are from Michigan, and this one showed that 4,000 surgeons were interviewed or evaluated in their use of telehealth during the COVID-19 pandemic. And you can see this is pretty early on. This starts in January of 2020. And what we found were that urologists and neurosurgeons were the highest adopters. And you might wonder why that is. And part of that may be that the neurosurgeons in particular were leveraging already existing telehealth networks that were very much in place for neurology in terms of stroke evaluation. And then the other thing that was very interesting about this paper was that it demonstrated that there's really only a small volume that was salvaged in terms of lost visits. So you can see during that period in April of 2020, that's where there was the greatest difference between the in-person and telemedicine evaluations, but we still lost out on a lot of volume at that point. This was another study from Michigan where they interviewed surgeons to find out what their experience was with telemedicine. Where did they go right and where did they go wrong? And interestingly, 80% reported that they got no training, no formal training in telemedicine. Although it took less time and there was a lot of positive comments in this study, they named that physical exams, lack of equipment and connection, and difficulty establishing rapport with the patient were the main barriers to actually implementing telemedicine. And 18% reported a reduced efficiency. So I found this very interesting, but I think that there's probably a correlation with the fact that there was such a decrease in such a small amount of formal telemedicine training provided to the people that participated in the study, and that's what the authors concluded as well. Now, what do the patients say about telemedicine? This was an interesting study that was facilitated by a survey that was sent out to Australian Royal Academy of Surgery fellows. They emailed questionnaires to their patients. They had over 1,000 consultations. These were 20% post-op visits, and 49% of them were using video visits. There were 79% male patients in the study, so interestingly, there was a real bias towards male patients and private practitioners. But they found a very high satisfaction rate amongst the patients, and 75% of the patients reported to find it equivalent to an in-person visit, despite what we just heard about how the surgeons felt in Michigan about their inability to engage with patients. I think the bottom line here is that patients tend to feel like this is a very convenient and cost-saving method of receiving care. And despite the fact that less than half of them preferred to have a telehealth visit in the future, I think that this, for the time being, is a really strong option, particularly as we're challenged in trying to get back to whatever normal is going to be. But I want to talk about this as a use case for following our patients after surgery, after they go home. And I've been thinking about this problem since I was a resident. I think that surgical site infection is the perfect use case for why we need to follow our patients more closely after they leave the hospital. This is an excellent study that was just published in November in Surgical Infections. And they reported, in looking at this case-controlled study of both patients that developed surgical site infections and those that did not, they found that 87% of the SSI cohort were diagnosed with SSI after they left the hospital. This is actually the highest rate I've seen in any study. And SSI was associated with a lower postoperative quality of life score, with less vitality, increased pain, and reduction in physical activities. I mean, none of this is going to be surprising at all to any of us, but the fact that this was actually documented in a journal for almost the first time in a prospective fashion is really important. So these patients with SSI reported lower satisfaction with their care overall. I think we should really internalize that as surgeons. This is something that we want to avoid, and obviously we want to prevent, but how do we do that, and how do we make it better for the patients that develop SSI after they go home? And I would argue that the way that we treat patients after they leave the hospital hasn't changed since you were a resident, even if you're an older surgeon. We still do 7 to 14-day post-discharge follow-up. We still give the same post-op wound care instructions. You probably are handing out a piece of paper that says the same thing that your attending did when you were a resident. We give the same advice over the phone. Well, if you think you have an infection, you should come to the ER. I can't tell what that looks like over the phone. No personalized follow-up windows, no risk stratification, no proactive attempt to avoid these ad hoc emergency clinic or ER visits. And this is despite the fact that we've adopted ERAS, new wound care protocols, increasingly regionalized surgical care delivery, and the emergence of telehealth during the COVID-19 pandemic. So I'm not the only one who's been thinking about this. This is a wonderful study that was published back in 2017. And John Semple, who is a plastic surgeon at the University of Toronto, did this randomized controlled trial using a mobile health app that he created to help his patients follow up with their wounds after surgery. And he randomized to a group that had usual postoperative care, and they were seeing their patients on post-op day 3 because they had drains, and they were removing their drains routinely then. And then they had patients that were followed by this mobile health app. And they found that the number of in-person visits was significantly lower in the first 30 days after the operation amongst the patients that used the mobile health app. And they also had no difference in their satisfaction with their care, but higher convenience scores. So once again, there's that convenience measure. This is a very new study that was just published at the end of 2021, which is a randomized controlled trial in emergency general surgery patients. And they had a different smartphone app, basically the same idea of following surgical wounds postoperatively at home to determine whether or not they were developing a surgical site infection. And the smartphone group, while in the Kaplan-Meier curve, you see that the p-value is not significant. Within the first 7 days post-op, there was a difference between the smartphone group and the usual care group with a higher odds of diagnosis within the first 7 days. They also had reduced in-person follow-up, and they had a better experience with access to care. So I think what this shows is that patients are really hungry for us to care about them. They want us to know when something is going wrong. And so there is this whole new category of telehealth that has developed in the last couple of years called remote patient monitoring. And essentially, the definition, according to CMS, is the use of monitoring devices for the transmission of patient vital sign data outside of the provider's organization. So for established patients, clinicians are able to bill for E&M services And you can use all of these different devices. There are others that are available, but these are sort of the main ones that we think of. A scale, blood pressure monitor, a pulse oximeter, and an EKG recorder. There have been some developments in device and data integration as well. Smart on Fire has been developed as a way to facilitate communication between devices and the EHR. There are also new devices that are out there that are allowing data transmission outside of cellular networks and Bluetooth via internet. These are just Bluetooth via a hub that you put in the patient's home, and so they don't even have to have an internet connection or a cell phone to be able to transmit data directly from their body. There are program innovations out there. Multiple different companies have developed these care coordination apps. There are many of us doing pilot and research apps. But I think the bigger thing that's happening is that many of the commercial EHR vendors are now including within their patient portals these RPM programs. So increasingly, you'll see that they're actually trying to facilitate better communication with patients and better integration of data that can be directly uploaded from devices that the patients are using. But that's not the only problem. And if you think about it, it's even more complicated than just giving the patient a device. Who's going to look at that data? Who's going to monitor it? Who's going to interpret it? Who's going to tell the surgeon when there's a problem? Because we're not looking at the EHR every moment of the day. We're certainly not opening every chart of every patient that we're caring for. And one of the paradigms that is being developed is that there would be a telehealth nurse or other provider that is an intermediary between the patient and the physician. We certainly already have nurses and LPNs and other staff members that answer the phone when patients call in and have a problem. But this is a different kind of intervention where someone would actually be monitoring and looking for these outlying values so that early intervention can happen. I want to mention two other things because there's a lot of development in telemedicine. One is virtual check-ins, which is essentially triage of new or established patients. It allows for audio-only telephone or two-way audio video or email or use of an online portal. And so this is the way that we can actually get remuneration for these services that we will usually just sort of offload and say, I'm going to call my patient and see how they're doing. You can actually bill for that as a virtual check-in. These are distinct from telehealth visits, which are newer established two-way audio, or e-visits, which are established patients via online portal only. So the primary purpose of these virtual check-ins is to establish whether you need to have an in-person visit with your patient. And so tailoring timing of postoperative visits and just-in-time rescue sort of falls in this category. So this is one way that some providers are figuring out how to get paid for these kind of monitoring. And then the final thing is remote therapeutic monitoring is brand new for 2022. This is intended for the management of patients that are utilizing medical devices collecting non-physiologic data, so pain levels, medication adherence, therapy adherence is recorded or reported by the patient via medical device. And these may include patient self-reported data captured by an app or a portal. This expands who can bill for these services as well. So for example, a physical therapist can use this, and it could be an opportunity for home rehabilitation after surgery as we think about that prehabilitation continuum. So in conclusion, there are a lot of telehealth options and it's getting more complicated. So post-op visits are covered by the global period, but maybe it's an opportunity for us to use this in efficiency with telehealth. These are very brief visits. These are check-ins to make sure, hey, how's your wound doing? How are you doing? Here's your pathology report. You don't really need to come back to the office for this kind of evaluation. Post-op monitoring options, triage, therapeutic monitoring, and remote patient monitoring for chronic conditions in the acute phase. So if someone has severe diabetes or other chronic health conditions that need monitoring anyway, this is an intense period where those things are going to be even more important and probably a time when these kind of monitoring options should be used intensively. But the big questions are, who does the monitoring? Who gets the data? Who gets the summary reports? Who gets the reimbursement? Can we be more efficient and facilitate better personalized care? Thank you.